everyone, and welcome to yet another module on the RRR Season 2 series that we are conducting before your exam. And today's topic will be clinical management. I hope you will enjoy this and this will be helpful in the upcoming exam. We are going to be discussing about a few important concepts and also a little bit on the image-based questions that are quite popular in the part 1 exam. So let's get going. And well, the most important concept that all of us must clear in our minds is about the fear before the exams. So preparing for exams often feels overwhelming, like it's like a storm in the mind. Well, the rain represents stress, self-doubt, and constant pressure to cover endless material. And we have all gone through this during the exam times. And it is natural that we feel lost and discouraged in, well, the downpour of all the stress. But we must also remember that rain nourishes growth. Every moment that you spend studying, revising, solving questions is like watering the seeds. And these seeds will eventually bloom into flowers, and your success and your confidence and the fulfillment of your dreams. So don't let the fears overwhelm you. Just keep studying. Now, the first question is from one of the most important topics and also a very popular one amongst the exam setters, that is gestational diabetes in pregnancy. Now, here we must know all the pre-pregnancy and during pregnancy and labor, all the cutoff values, when should we call the patient for follow-up, and also the management regimes. So here we want to know at what HbA1c level should pregnancy be avoided. So a patient has come in her preconceptional counseling, and what is the HbA1c level that we should counsel her that you should avoid pregnancy. And the options are A, more than 64, B, more than 48, C, more than 75, D, more than 86, and E, more than 102. Now, the one thing that is most important to remember here is that these values are in millimoles per mole. And a lot of us are used to talking about HbA1c in percentages. Now, it is important for the exam that we remember both these values because they may or may not give you in percentages. So it is a good idea that we have both the values in our mind. Now, I'm sure most of you know the answer, but let's proceed to the answer. At what HbA1c level should pregnancy be avoided? The right answer is option D, HbA1c more than 86 millimoles per mole, which is around 10%. And pregnancy should ideally be planned when the HbA1c is under 48 millimoles per mole, which is around 6.5%. Along with this, one must know which GTT is being used. Is it the 75 grams or the 100 grams? So mostly we are using the 75 grams glucose tolerance test. What are the cutoff levels? Well, to diagnose a patient with gestational diabetes, the cutoff levels that we use are 5.6 and 7.8. So the fasting is 5.6 and the postprandial or post-glucose drink after 2 hours, it should not be more than 7.8. And an easy way to remember is 5, 6, 7, 8. And what are the cutoff levels that one should maintain during pregnancy, in type 1 diabetes, and in labor? What are the cutoff levels that we should be keeping the patient at? These are some important points that one must note in this topic. Okay, so the next question is, what is the diagnosis for urine leakage on coughing or sneezing? So a patient has come to us and she's saying that she's leaking urine only on coughing or sneezing. So what do we provisionally diagnose her as? A, urge incontinence, B, overflow incontinence, C, stress incontinence, D, functional incontinence, or E, mixed incontinence. Now let's proceed to the answer. So what is the diagnosis? It is C, stress incontinence. This is when incontinence happens when the intra-abdominal pressure increases, which happens during episodes of coughing, sneezing, or exercise, and also in the presence of weakened pelvic floor muscles. Now, what is urge incontinence? Urge incontinence is a sudden urge to pass urine, and it is associated with detrusor overactivity. It is not stress that is triggering it. Overflow incontinence is like incomplete bladder emptying due to obstruction or weak bladder contractions, which leads to dribbling. What is functional incontinence? This is actually caused by physical or certain cognitive barriers to reaching the toilet in time, and it is not related to stress or coughing or sneezing. Mixed, of course, as the name implies, it is a combined feature of both stress and urge incontinence, but it does not exclusively explain leakage during only coughing and sneezing. So it is a mixed incontinence. So stress incontinence is the answer. It is linked to weakened pelvic floor muscles, and the first line of treatment is pelvic floor muscle training, which requires strengthening exercises, or if that doesn't work, then proceeding to surgical interventions. Now, since we are at the topic of incontinence, this is a cystometry graph. Okay, so let's go through the question, then let's discuss the graph and how to interpret it. A 50-year-old woman presents with urgency, frequency more than 10 times during the day and 2 to 3 times at night. She has no urge or stress incontinence, and her filling cystometry trace is shown below. So what is the most likely diagnosis? Is it urodynamic stress incontinence, mixed urinary incontinence, interrupted flow, detrusor overactivity incontinence, or detrusor overactivity? Now let's move on to the next slide and see how we interpret a graph. So to be able to understand these graphs and to interpret any kind of variations that they might give us in the exam, we must understand what is cystometry and what are the lines that the graph is representing. So cystometry is nothing but a test that helps us to understand how the bladder is working. So we are measuring how much the bladder can hold and how well it can store urine. So it's a very easy analogy to liken the bladder to a balloon, and you're first filling up with urine, so that's the filling phase, and then you reach a point when the balloon can fill no more. So that's the point that the voiding phase starts. Now the three important lines that you have to see on the graph are the bladder pressure or the vesical pressure, which is how much pressure is there inside the bladder. Then you have the abdominal pressure, which is the pressure from the abdominal muscles or any pressure which is from outside the bladder. And of course, there's the detrusor pressure, which is the bladder muscles activity. And this is usually calculated by subtracting the abdominal pressure from the bladder pressure. Now we must, usually it is kind of a norm that they mention the vesical pressure, then the abdominal pressure and the detrusor pressure, but they can give you graphs in any order. So what we first need to note is what is mentioned on the side of the graph, which line or which segment of the graph is representing which kind of pressure. So is it the abdominal pressure, where is it, and is it on top or bottom? So the graphs can vary. So we must see that before we start interpreting. Now let's move on to our graph in the question and see what the answer is. So before we move on to the answer, let's see this graph and see what these lines are representing. So the red line is the vesical pressure or the PVES. The green line is the detrusor pressure or the PDET, and the blue line is the abdominal pressure, which is the P abdomen. So on this graph here on the right, we can see that the blue line is almost horizontal and there are no upward movements on it. However, the green and the red are showing sharp increases. So this is involuntary contraction of the detrusor muscle, and which is causing the vesical pressure also to increase. However, it is not associated with increase in abdominal pressure. Therefore, this is not typically seen in stress incontinence. Here, however, when we see this graph, here The red line, which is the bladder pressure or the vesical pressure or the PVES, and the abdominal pressure, which is marked in blue, which is the P abdomen, is increasing. So when does the P abdomen increase? When there is a increased pressure in the abdomen due to any exercise or cough. So when the abdominal pressure is increasing, the bladder is also increasing in pressure, and that is what will give rise to stress incontinence. Now, episodes of incontinence are marked with leak, so they will actually write leak over there. Okay, if it is not marked as leak, then this is what is happening in normal bodies. When you are coughing, there is a pressure transmitted to the bladder. However, there is no incontinence. But when leak is present, that is called as stress incontinence. Now let's move on to our graph and see what the answer is there. So this is the graph that we were given, and we were told that this is the filling cystometry. So we need to know which of these lines represents what, as the P abdomen, vesicle and detrusor can be mentioned in any order. So on top we have here the abdominal pressure, and in the middle is the vesical pressure, and on the bottom line, which is shown by red, is the detrusor pressure. So what do we see here in the filling cystometry is the abdominal pressure is more or less constant. However, there is a sudden rise in the detrusor pressure, which is of course transmitting it to the bladder, and they have not mentioned any leak. So what do you think the answer could be? So well, here we are. Our answer is detrusor overactivity. Why is it not detrusor overactivity incontinence? Because there is no episode of leak which has been marked in the graph. If there was a leak, then the answer would have been detrusor overactivity incontinence. So the urodynamic observation characterized by involuntary detrusor contraction during the filling phase, which may be spontaneous or provoked. And since there is no leakage of urine at the time of detrusor contraction, we will mark our answer as E, detrusor overactivity. So I hope the concept is a little clear now, and you will be able to interpret any graph that you come across in the exam. So this here is an image-based question, and it reads that a 43-year-old woman presents with heavy menstrual bleeding and dysmenorrhea. A hysterectomy is performed, and a cross-section of the uterus has been shown below. What is the diagnosis based on the image? Is it a leiomyoma? Is it an endometrial carcinoma, an adenomyotic lesion, endometriosis, or chronic endometritis? Now, this is a beautiful image, and see what you can see here, and let's see what the answer is. So what this image actually shows is endometrial glands and stroma, which is located within the myometrium. So this is causing the thickening of the uterine wall, and these patients present with heavy painful menstrual bleeding and a diffusely enlarged uterus. So our diagnosis will be adenomyosis, which is option C. So of course, ultrasound is a very useful modality in diagnosing adenomyosis. So you can expect that instead of a histopathological specimen, they might give you an image of an ultrasound or an MRI, which is actually the modality of choice to actually characterize adenomyosis. So these are images from an ultrasound and the MRI, and you must be able to discern these images and interpret them according to the various features, and if they give you this in the exam, then you'll be sure of your answer. Well, let's see what we have here now. This is a 30-year-old woman who's presenting with chronic lower abdominal pain and an ovarian mass identified on ultrasound. Now, a surgical specimen is shown below. What is your most likely diagnosis? So, clearly you can see a lot of things within this cavity of this tumor. So what do you think it is? Is it a granulosa cell tumor, endometrioma, mature cystic teratoma, or a dermoid cyst? Whether it's a serous cystadenoma or a mucinous cystadenoma. So our answer here is mature cystic teratoma or a dermoid cyst. And we must know that this is the most common ovarian tumor in women of reproductive age. Let's see a little bit more about mature cystic teratoma and other kind of images that might be given to you in the exam so that it's a clear-cut answer for all of you. So in the image that was given to us in the question, we saw a mature cystic teratoma because there was presence of hair and other differentiated tissues within the cyst. Now, they can also provide you with ultrasound images in which you will be able to see different kind of textures, and it's easy to diagnose even on the ultrasound. So, like I said, one of the most common ovarian tumors are mature cystic teratomas, which are also called as dermoid cyst, and these are usually benign but can present with pain because they are most likely to get torted or ruptured, and there is a risk of malignancy in less than 2% of these patients, and the risk of malignancy is more in postmenopausal women, and the treatment of choice here is surgery. Now this is a specimen, and they have given a vignette of a 49-year-old woman who has presented to her GP with complaints of irregular uterine bleeding over the past 6 months. The bleeding is particularly heavy after her last period, and she's perimenopausal, she's 49 years old, and reports no history of significant gynecological issues prior to this. An ultrasound reveals a small hyperechoic lesion in the endometrial cavity, and following hysteroscopy and biopsy, the histopathological report corresponds to the structure shown in the image that has been given. Now, you have to identify the structure which has been marked with this arrow here, whether it is a submucosal fibroid, an endometrial polyp, endometrial hyperplasia, adenomyosis, or retained products of conception. So our answer here is an endometrial polyp, and it is actually a benign lesion which arises from the endometrium, and they project into the uterine cavity and can cause abnormal uterine bleeding, especially in perimenopausal women. They are often identified on the ultrasound as focal hyperechoic areas, and their diagnosis is confirmed histologically. So here I have tweaked the question a little bit. So let's see what the question reads now. It's a 49-year-old woman who has presented to the GP with complaints of irregular uterine bleeding over the past 6 months, and it is particularly heavy after her last period. She is perimenopausal and reports no history of significant gynecological issues. An ultrasound reveals a small hyperechoic lesion in the endometrial cavity. You have to identify the structure which has been marked with an arrow, and now the options remain the same. So let's see what the answer is. Again, the answer is an endometrial polyp, which I have told you what it is. Now, this commonly occurs in peri and postmenopausal women and presents with abnormal uterine bleeding. The tests that we use to diagnose it are ultrasound and hysteroscopy, which are the primary diagnostic modalities for detecting these polyps. And if they are causing symptoms, or if they are occurring in postmenopausal women, they should be removed due to the small risk of malignancy that is associated with them. Now, endometrial polyp, like we've already described, is a usually benign lesion in the lining of the uterus, and it projects into the endometrial cavity and can produce symptoms such as heavy uterine bleeding, irregular intermenstrual bleeding, and also postmenopausal bleeding. Okay, so now what we have here is a 25 years old girl who has presented with sudden pain in the abdomen. Ultrasound shows an ovarian cyst. She has regular cycles with history of dysmenorrhea, and she used to take ibuprofen for the pain. An ultrasound image has been provided, and you've been told that her LMP was 3 weeks ago, and you have to make a diagnosis between A. corpus luteal cyst, hemorrhagic cyst, ovarian torsion, endometriosis, and ovarian carcinoma. So what do you think this could be? Well, let's move to the answer. So the answer is an endometriotic lesion. So ultrasound is particularly sensitive for accurately diagnosing typical endometriomas and most commonly in premenopausal women. Now, typically an endometrioma is unilocular and has low level echogenicities, which are actually representative of old blood in the cyst cavity, and this gives rise to the typical ground glass appearance of an endometrioma, and this is one of its typical feature, and you can reach your diagnosis with this. So this is actually a chart or an image which is showing you the various features that can present on the ultrasound and which may be either benign or malignant. So what you have to look out for, they might give you these lesions and ask you to calculate the RMI, or just simply diagnose whether they are benign or malignant, and about the various features. So this is a very beautiful image, and I thought you will find it very useful. Moving on, we have a 35 years old multi who had a vaginal delivery a month back, and she came for IUCD insertion 2 days ago. Now, since the IUCD insertion, she is complaining of severe dyspareunia, and a scan is done which shows the following picture. Now, we have to identify the location, whether it is in the uterine cavity, whether it is in the abdominal cavity. Option C says perforated through posterior uterine wall. D, IUCD is not seen. And E, is it embedded in the posterior myometrium of the lower uterine segment? So yes, our answer is option E, it is embedded in the posterior myometrium. Now, myometrial penetration of an intrauterine device results in an eccentric positioning of the IUD, and it is within the endometrial cavity or the uterine cavity, but in the myometrium. And the linear hyperechoic arms of the intrauterine device, they actually breach the basal layer of the endometrium and extend into the myometrium. So a 3D imaging in the coronal plane has actually kind of improved the sonographic details of the intrauterine devices by enhancing visualization of the shape of and location of the device within the endometrial cavity. So they can give you various images like these, okay, in which they will ask you to identify what is the position. So as you can see, and you must know what is the normal positioning also, and here the intrauterine device is displaced lower down into the endometrial cavity. It is not in the myometrium, it is still in the endometrial cavity. Or they can give you an X-ray with a displaced intrauterine device and ask you to identify, or just tell you whether it is misplaced and where is it in the abdomen, or like that. Now here this image wants to actually show us what are the most likely sites of perforation while inserting an intrauterine contraceptive device. If the uterus is anteverted, then the most likely perforation will be through the posterior wall, and if it is a retroverted uterus, then you're getting a chance of having anterior perforations. So this diagram depicts that. Okay, so a question linked to this only. There's a woman who has been referred to the gynecologist for removal of her intrauterine contraceptive device, and on examination you were not able to see the threads. So an ultrasound was done, which again showed that there is no intrauterine contraceptive device in the uterine cavity. So what would your next step be? Would you do a uterine sounding? Would you do a hysteroscopy? Would you perform a laparoscopy? You would do an abdominopelvic X-ray or a lateral X-ray pelvimetry. So basically you have not been able to see the intrauterine contraceptive device, so the threads, and the ultrasound also does not show. So what do you think you should be doing? So here is a kind of an algorithm in which you can see the various possibilities when the threads are missing. So you've done an ultrasound and it is asking you whether have you seen the intrauterine device. So our answer here is no, we have not seen it. So what is our next step? We will do an X-ray pelvimetry to see if it is there in the abdominal cavity and proceed according to the findings. So this is a very useful kind of an algorithm. So maybe if you could go through it, it will help you. So here in our question, what would you do? Our answer is, of course, abdominopelvic X-ray. Now, since we are discussing IUCDs, a quick update on what the FSRH says on insertion of IUC after delivery. So it says IUCDs can be safely inserted immediately after birth, that is within 10 minutes of delivery of the placenta, or within the first 48 hours after uncomplicated cesarean section or after vaginal birth. So after 48 hours, if you've not inserted the IUCD within the time period, then you should delay the insertion until 28 days after childbirth. So it is either at delivery of the placenta or after vaginal delivery within 10 minutes of delivery of the placenta. Contraindications will include prolonged rupture of membranes, unresolved postpartum hemorrhage and sepsis for obvious reasons. Risk of perforation is actually reduced compared to delayed insertion since the myometrium is thick in the period immediately after childbirth. Also, there is no increase in the risk of infection. Now, it has been noted that there are higher expulsion rates, but there are also higher continuation rates 6 to 12 months postpartum. Now, this expulsion is most likely to occur in the first 3 months after insertion, and expulsion rates may be lower for post-placental insertion after cesarean rather than after vaginal. So that's a very interesting point. Now, what FSRH and all the researchers feel is that as long as expulsion is recognized and alternative contraception provided or a replacement IUCD inserted, this should not be regarded as a reason for not providing IUCD immediately after delivery. So basically, all in all, benefits outweigh the risk, and it is safe to insert IUCDs immediately following delivery. Okay, so now you're very close to your exam, and we are all here wishing and praying that you all do really well, and you've actually come so far, worked really hard, all your dedication and all your perseverance. We've seen you having all those confusion, all your doubts, all your fears, all your insecurities, and you've worked through them, all the distractions, all the obstacles that might have been there. I'm sure there would have been a lot of stresses in your individual situations which you've overcome and come so far. So hats off to your dedication and perseverance, and now it's time that you should soar high and go and achieve all the success that you all really deserve. So the sky should not be the limit for all of you. Soar high and make your dreams a reality. All the best to all of you. So thank you for listening in and joining our RRR series. You must leave a feedback, and also if you have any questions, do post in the comments and we will definitely get back to you. And like I said, wish you the very, very best. We're looking forward to hearing from all of you after your exams. Bye.